MERS-CoV testing in Saudi Arabia and Pakistan. MERS-CoV, also known as Middle Eastern Respiratory Syndrome or MERS, is an illness caused by a coronavirus that leads to respiratory issues like coughing and shortness of breath. The disease is new to humans as it was first identified in Saudi Arabia in 2012. MERS spreads through the infected person's respiratory secretions, but the exact process of how it spreads is not understood. The main reservoir host is thought to be dromedary camels, but other unknown animal reservoirs may exist. People with pre-existing health conditions and immunocompromised persons are at higher risk of contracting MERS, and it is recommended for all individuals to avoid exposure to dromedary camels. Primary transmission is the transmission of the illness that does not involve contact with an infected human and can possibly be a result of contact with a dromedary camel. During secondary transmission, MERS is spread through human-to-human contact and is usually described as either healthcare-associated or household-associated. The median incubation period of MERS is about 5 days, but can range from 2 to 14 days, and the symptoms can vary.
Now we're looking to the prevalence of MERS in both Pakistan and Saudi Arabia in both humans and camels. Currently in Pakistan, there are no confirmed cases of MERS in humans. However, it's different in the camel population. In 2018, a study was conducted where 1,050 camels from 4 different provinces in Pakistan were tested via nasal swabs and serums for antibodies for MERS. The results of the study concluded that out of the 1,050 camels, 794 tested positive to carry the MERS antibody. Like Maya mentioned earlier, the first case of MERS was actually in Saudi Arabia in 2012. Since then, the majority of cases of MERS have come from Saudi Arabia. As of January 2020, Saudi Arabia has a total of 2,106 confirmed cases of MERS and 783 related deaths since the outbreak in 2012. Camel-wise, a study conducted in 2017 found out of 266,000 camels in Saudi Arabia, only 977 tested positive for MERS.
Like Atiya had mentioned before, we have decided to investigate the prevalence of MERS in Pakistan, which is low income, and Saudi Arabia, which is high income, and compare and contrast some ways that both countries combat the virus. We will start by looking at Pakistan. While it is true that there have not been any official reported cases in Pakistan, they are still taking precautions to ensure that an outbreak of the virus does not happen in their country. Currently, something they are doing to combat the virus is to screen possible cases through not only collecting nasal and throat swabs, but fecal, urine, and blood samples as well. While this is very comprehensive, it is also expensive. With Pakistan being a low-income country, it is hard for this kind of testing to be done regularly, so Pakistan only does it on severe probable cases. While the National Institute of Health in Islamabad, the capital of Pakistan, has outlined testing criteria and testing protocols for hospitals and laboratories, they have given very vague information on how hospitals are to deal with this virus through infection control and prevention. Unfortunately, if hospitals do not have ICP protocols solidified, that can detrimentally impact the presence the virus could have in that country in the event of an outbreak. The NIH in Islamabad identified 2 overarching scenarios where testing needs to occur. These scenarios are very detailed and seem to be tailored towards a specific group of people. This is because the country, low in resources and funding, has dedicated the resources they have to cases they know will most likely return with positive results. Most countries, like Saudi Arabia, include a wider criterion for testing in order to detect more true positive cases. This list was compiled to exhibit current conditions and areas of improvement within Pakistani hospitals. As you can see, there are 3 classifying types of ICP measures: administrative control, environmental control, and use of PPE. In Pakistan, there is confusion over correct guidelines to follow because recommendations from other countries have been different. Because of this, there have not been official guidelines established pertaining to this disease. With that follows a lack of training for the healthcare workers within the hospital, and without proper guidelines in place, how could the workers be trained on how to respond and treat patients? The environmental control measures are more solidified because the general NIH guidelines explicitly state that confirmed patients are to be placed within an AIIR, or airborne infection isolation room, and that transportation should be limited. The final measure, or use of PPE, was the one lacking the most official guidance. Within Pakistani hospitals, standard operating procedures do not exist on the type of PPE that should be worn and when. Therefore, healthcare workers tend to decide just to not wear any PPE like gloves, face masks, gowns, etc. Or if they do wear it, they don't understand disposable methods or the dangers of reusing PPE. Unfortunately, there is already a shortage of PPE, so in the event of an outbreak, their resources would be even less. All these measures identify areas that Pakistani hospitals need to improve in order to be properly prepared in the event of an outbreak.
In Saudi Arabia, surveillance and testing is extensive and widespread due to a partnership with the CDC. Before this partnership, Saudi Arabia's Ministry of Health had problems with contracts not doing what they were supposed to do. These contracts were suspended for not helping with lab testing, not training medical staff, and failing to create future strategies for MERS response. The CDC stepped in to help provide training with Saudi health professionals in epidemiological and infection control practices. They also provided support and expertise for ongoing MERS research. The CDC helps to conduct studies in Saudi Arabia, but in this presentation, we're focusing on a specific study that showed the proper implementation of surveillance that provided data that gives a more accurate representation of MERS prevalence. The robust testing throughout Saudi Arabia during April 2015 to February 2016 helped determine that over 80% of MERS cases were found here. People were tested under routine surveillance as they met a certain criteria. Those tested had to meet one of the 4 case definitions provided by the study. People with community-acquired pneumonia, healthcare-associated pneumonia, symptoms after exposure to a MERS case patient, and an unexplained fetal illness. There are tests reserved for children with exposure to camels, camel products, or confirmed or suspected MERS case patients. Lastly, testing is recommended for people with close contact to MERS patients, even if they don't have symptoms. These tests can be requested by an infectious disease consultant. The criteria for if a person needed to get tested cover many areas, which explains in part how testing was extensive and widespread. The study found that 384 people out of 57,363 that were tested had MERS. This was less than 1% of people tested. The routine testing that these individuals participated in allows them to be informed of their status and receive proper follow-up care. The criteria proved to cover groups of people that were most susceptible to MERS. 89% met the criteria, and the other 11% got tested due to being recommended by a doctor. The study showed the extent of testing with over 5,000 people being tested per month. Extensive testing helps to determine an accurate prevalence rate. This early extensive routine testing of MERS cases allows for proper infection control precautions and prevention to take place.
The World Health Organization has recommendations for implementing interventions to control the spread of infectious diseases, the most important aspect being to maintain ethical standards. While there is some testing being done in Pakistan, it does not cover all that are at risk. Due to having positive cases of MERS in camels within Pakistan, there is a larger at-risk population. Following the World Health Organization guidelines by implementing routine testing would present more accurate numbers and prevent the spread of MERS with early detection. Because Pakistan is categorized as a low-income country, it is essential to form partnerships for funding. Having proper trained health professionals will not only result in effective treatment, but also protect the healthcare staff from being infected. The government officials of Pakistan should then be transparent to their people and with larger organizations like the World Health Organization, so that proper monitoring and safety precautions can be put in place. Saudi Arabia already has intervention measures in place. However, there are ways to improve upon their effectiveness. Increasing trust and being transparent can make people want to seek help and treatment if exposed. Forming new partnerships can create more funding opportunities that will expand resources for screening and treatment. Due to their high number in cases, Saudi Arabia is dedicated to reducing new cases, but maintaining that dedication can hopefully lead to an elimination of all new cases. And here are our resources.